Welcome to this edition of AFMC.
I'll tell you how I got better. I'm
Glad to be here.
But a mission to
Delivery of
Well, I think that we're
going to talk about everybody's.
Arkansas is the second highest prescriber.
Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Tuhin Virmani. He is not only an MD, but a PhD in neurology and also oversees the Virmani Gait laboratory at UAMS. Dr. Virmani, thank you so much for joining us today.
Thank you for having me.
So tell me a little bit about your work.
So I wear a couple of hats, as you mentioned. So I'm a clinical neurologist specialized in movement disorders. So I see patients in our movement disorders clinic that range primarily with Parkinson's disease, but also other movement disorders like Huntington's disease and the like. And then I do research primarily in Parkinson's disease again, trying to learn more about people's progression in the disease and how we may be able to better inform people clinically as to how they may progress through the process, as opposed to kind of just we don't have good ways of guiding people in particular as to how they will progress as the disease carries on.
And tell us, how is it diagnosed typically?
Yeah, so the disease is still diagnosed clinically. So there are a set of things that we ask people about when we're talking to them when they come into clinic, but primarily the diagnosis is based on, again, the physical exam findings. So there are four main features we're looking for when we're trying to determine if someone has Parkinson's disease. One is the resting tremor that people most commonly associate with Parkinson's disease. When you see someone shaking, it's kind of this pronation, supination, or pill rolling type of tremor. The second thing is called muscle rigidity or stiffness. So people, when we move their muscles around, they're stiffer than you would expect them to be. And often people, when you're talking to them, will tell you they feel weak when they walk, but Parkinson's doesn't really cause muscle weakness. It's that stiffness in the muscles that people perceive as weakness. And the third thing we're looking for is something called bradykinesia. And so people with Parkinson's will tell you they're slow in their movements and they have difficulty with tasks that require dexterity. And on our examination, we see that in the form of a tapering amplitude with repetitive movements, and that's what causes that difficulty with fine-fingered dexterous tasks. And then the last thing we're looking for is postural instability. So we pull people backwards at the shoulders, and as the disease progresses, it's not typically something that happens early on, but as the disease progresses, that ability to recover when your center of gravity is pulled backwards is decreased over time, and people will fall, or we have to take multiple steps to recover their balance. And so you have to have one of those criteria, which is that bradykinesia that I talked about, and one of the other three criteria in the rigidity, tremor, and postural instability. And so the important point there is we often think of Parkinson's as tremor, but you do not have to have tremor to have a diagnosis of Parkinson's disease. And I think that's a lot of the consults we get where people get confused that, oh, I don't have tremors, so why are you telling me I have Parkinson's?
And our healthcare providers, do they refer them to your clinic? How do you see patients?
Yeah, so since we are a tertiary medical center, we're the only movement disorders, well, we're one of two movement disorder centers in the state. We have 4 movement disorders trained neurologists here, and there's one other person we do collaborate with at Washington Regional in Fayetteville, Dr. Alan Diamond, but there are just 5 of us in the entire state. So primary care providers can refer people in, neurologists can refer people in, and then often we work together with the community neurologists if that's what the patient would like to do, or we also see patients regularly who would like to follow with us.
And should PCPs manage the illness, or is that something you strictly want to come from your clinic?
Yeah, that's a great question. I think it is important for people with Parkinson's to be seen at least once early on in their course by a specialized center, because there are a lot of clinical trials taking place right now, and those trials are geared towards people who are recently diagnosed to try and maybe delay the progression of the disease. We currently don't have any medications that can help prevent the process from progressing. And so that's the only way people will potentially have access to those drugs that may slow down the disease, by participating in a clinical trial. And they really need to be seen at a specialized center where we have access to those trials, to be able to participate potentially and get earlier treatments that may take, another decade to get on the market.
And there are some advanced therapies that you guys are using as well, correct?
Correct, yeah. So we're the only center in the state that does the deep brain stimulator surgery for Parkinson's disease, and that's more for advanced disease, but we're using it earlier and earlier in the process. So unless you're kind of part of that center where we're thinking about these things and maybe finding that you may be a candidate earlier than someone else may think you're a candidate, you wouldn't maybe know about it, and you may miss the window where that's available. The other therapy that we're the only ones that do in the state are levodopa infusion therapies. So normally people take pills and their medications can kick in, they get better for a couple of hours, and they as the medication comes out of your bloodstream, your symptoms come back. And again, that's usually more later in the disease. But we now have this infusion therapy where we can put a tube into the stomach and constantly infuse the medication. So you're not having to deal with those ups and downs in your function throughout the day. Additionally, people with Parkinson's, also have dystonia, where their muscles can tighten up to the point where they curl in. And so we're the only center in the state that does botulinum toxin injections, or have been trained to do botulinum toxin injections for Parkinson's dystonia. There are other neurologists and providers that do the injections, but we're the only group that's kind of done a fellowship training specifically to treat Parkinson's and movement disorders.
And there are clinical trials that are a part of this research, or is it additional things that you're offering there?
Right. So research is important, but it's not for everyone. But we do offer a lot of different clinical trials here. Not all of our patients participate, and you don't have to participate to be seen at our center clinically. It's just something that we offer in addition that might be of interest to some people, because unless we have people with the disease participate in trying to help us develop a cure, we can't develop a cure. We need participation from people who already, unfortunately, have had the disease, and their help may help others in the future. And so we do have a lot of people who feel that way and do help out. And in addition to those early trials where, we're trying to develop ways to prevent progression, we also have trials that are trying to find better drugs to treat the symptoms. So there are potential clinical trial options all through the progression of the disease.
But tell us about Gait in Parkinson's and how that progresses.
Yeah, Gait is very interesting, and unfortunately, it progresses very differently in different people, and we still currently don't have ways of saying that person that you're seeing today may be walking perfectly well 10, 15, 20 years from now, whereas somebody else may start developing different problems of gait. The one that I'm most interested in is called freezing of gait, where people feel like their feet are kind of just stuck or glued to the ground, and they have difficulty moving for a couple of seconds, and that can lead to falls. And of course, the problem with falling, if you're an older adult, is you could fracture a hip or fracture an elbow or something. So we are studying that in the lab. We're not doing any clinical trials yet. We're working on starting one, but we are basically just monitoring people more objectively. So we're measuring their walking using a pressure sensor mat. So there's a mat with a layer of pressure sensors in it. So when people walk, we can see their footsteps on the mat. We have these accelerometers that we put on people's elbows and wrists and feet that, again, track how well their arms are moving when they walk or how well their body is moving when they walk. We have a digitizing tablet that digitizes their handwriting, so to track how that's changing over time, because people with Parkinson's tend to write smaller and smaller. We have gloves that measure how well their fingers are moving. So we have a lot of toys in the lab to try and better define how a particular person is progressing. And we actually give back that information to our participants as well, so that they like seeing their trends over time and seeing that, hey, I'm actually doing well, even though I think I'm not. And so that's also helpful to the participants. Plus, it gives us information to maybe help predict development of those different gait features in a particular person.
And primary care doctors don't have to be the only ones that refer patients. Can patients self-refer?
Yes and no. So we do get a lot of patients who call us and ask us if they can be seen, and that sort of helps them get into the queue and learn about what we're doing and whether they want to be seen here. But because we are a tertiary referral center, mainly for insurance purposes, we do have to have a referral, because otherwise their particular insurance may not cover the visit. If that's not a problem to someone, then of course we're happy to see them. But these days, it's easier if your insurance provider is covering your visits, especially if we're doing advanced therapies. Then those can get pretty expensive pretty quickly.
And is it just Arkansans, or do you see patients from anywhere?
We see patients. We have a pretty large catchment area, again, because we're sort of and we're centrally located in Arkansas. So we do get a lot of patients from Memphis and kind of bordering Tennessee, the southern border of Missouri. We have patients from Oklahoma and Texas, and then the northern border of Louisiana who drive to us, because for some of them it's easier to get to us than it is to get to, say, St. Louis or Dallas or Nashville.
And you mentioned about specialized care with Gait and all these really, I say, cool advanced technologies that you use. Video assessments are a part of that as well. And is telemedicine a part of this?
Yeah, so that was something that we got interested, actually, even before the pandemic hit. It sort of blew up as far as a research topic because of the pandemic, and everybody was staying at home and unable to get in. But movement disorders sort of lends itself towards telemedicine, because a lot of the clinical trials that have been done in the past all took videos, and people were rating the exam on a video rather than physically in person with a participant. And so what we've been trying to do is UAMS has regional centers around the state, and so we're trying to utilize those regional centers to help people who maybe drive in 3 to 4 hours to see us. Maybe they can drive 20 minutes to their local center in Fort Smith, and I can see them over a pretty good broadband video connection and still be able to get the nursing support with the blood pressure monitoring, and also still be able to do some of the extra things that we can't do at home. But it still saves them 3-hour plus return trip, gas, food, all that extra stuff that comes with having to travel in.
Well, you've given us a lot of information, so interesting in the work that you're doing. Tell me what type of misconceptions are out there that you want people, healthcare providers, to know about Parkinson's and your work.
Yeah, I think the biggest misconception that we like to get out is that, often when people get a diagnosis of a neurodegenerative disorder, or even any neurology disorder, actually, people often think that, that's it. And, now I'm living towards the end. And really, that's not the case anymore. Parkinson's disease, the symptoms are very treatable. And so if you're unfortunately seeing someone who's telling you kind of that's it, go home and hang out. We don't want that. There's a lot that you can do. You can live a very good, high quality life for many years, and we're talking months or weeks. We're talking decade. And so we want people to remain active. We want them to exercise. We want them to help keep active, keep social, keep doing the things you want to do in the prime of your life when you've worked and now you have this time to do all these things. We want you to keep doing them. And that's our main goal in the clinic. And I think all of us work towards that. We're not just trying to give you medications because you have Parkinson's disease. We spend a lot of time individualizing care for each patient as to what they need and what they want to get out of their lives. And so we try and help them through that process and realize that people don't die because of Parkinson's, they die with Parkinson's. And so you still have to live your life. And we try and encourage those positive thoughts.
Well, Dr. Virmani, it was a pleasure talking to you, and thank you for all the work that you do. It's so interesting, and thank you for all the lives that you're changing across the country, not just in Arkansas. Thank you.
Thank you.
And that's it for this episode of AFMC TV. I'm Robin Ledbetter. Thanks for watching, and have a great day.